Time for the for the meeting has arrived. There was a typo on the notice. This obviously is not a joint House-Senate meeting. We did have a joint House-Senate public hearing on Friday, and we certainly are working well with the Senate, but not quite that well. So, anyway, the time for the meeting has arrived. Obviously, members and some other folks are coming in, but Bill Todd was here and on time, and you may go first, sir.
Thank you, Mr. Chairman. Alan Wills, our Chief Financial Officer, will pass out some supporting documentation. Appreciate the chance to be here and talk about the Georgia Cancer Coalition. I am Bill Todd, Director of the Coalition, and enjoy being called to do this work. I'll be speaking from page 12 of the tracking sheet in addition to the supplemental information that's being passed out, page 12 of 13, the section in the University System of Georgia, 39.23, payments to the Georgia Cancer Coalition. We've talked a good bit in this committee over the last couple of years about the Georgia Cancer Quality Information Exchange, which builds on some landmark work that the Institute of Medicine did for us to determine the metrics by which Georgia should measure improvements in cancer care across the state. They gave us 52 metrics. We're in the process of building a dashboard to display those and to be able to share with providers, physicians, public health, hospitals, hospices, all the people who are involved in the cancer continuum, how things are going. During this past year, we completed the demonstration projects that had been funded in Savannah, Rome, Atlanta, and Columbus. And so it does show that this work can be done, that these disparate bits of information throughout medical records, public health information, and elsewhere can be collected. We have demonstrated that it can be done, and now we're involved in a proof of concept to show that the technology can work. We have a vendor who's under contract who's begun the work in Columbus, Savannah, and Atlanta, and Rome, excuse me. And that work is underway. You'll see the governor's recommending a significant reduction of over $4 million to this project. That was a one-time fund, according to the plan, for us to see if we could raise matching money from the private sector, foundations, corporations, or the federal government. What we learned was that it's impossible to do that until this technology proof of concept is complete. So the governor's recommending that that be pulled back because that was a one-time opportunity in the last fiscal year, the current fiscal year. The other reductions involve the regional coalitions, a small 10% reduction. We've talked about those regional cancer coalitions an awful lot in this committee, and I'm pleased to share with you that the relationships with the regional cancer coalitions are better than ever before. And although no one appreciates a $25,000 per region reduction in this recommendation, everybody understands that we need to be a part of the team and reduce accordingly. Greg Dent appeared before your public hearing, I think, on Friday, Mr. Chairman, and acknowledged that they could make do and try to replace those funds with funds that were raised privately or federally. In order to continue the momentum, in order to take this proof of concept and move it forward and distribute it to all 39 ACOS-accredited hospitals around the state, we are turning to the stimulus package. There's an awful lot of healthcare IT in this package. It's located in some 7 different places in the stimulus package, and so we're aggressively working with our colleagues across the state to make a pitch and continue that momentum. But the Cancer Coalition overall is, according to this budget recommendation, moving from 16,087 to 11,509. We think we can continue the momentum with that. Fortunately, we were able to preserve enough funds for 22 more cancer scholars. We had an experiment in this current year that's proving to be very successful to move some of those scholars, not just in the academic medical centers and our medical schools, but to community hospitals throughout the state, because 85% of cancer care is actually delivered in community health care settings. So we have an experiment underway now that's already proving to be very successful and popular, with one of those scholars in Savannah, one in Albany, and this year we would hope to have 3 more in community hospitals out in the state, in addition to the rest of them going to the traditional places in our academic medical centers. We think we can continue the momentum. We think we can implement the Quality Information Exchange and hire another 22 scholars to come into the state to address what we don't know about cancer care and find the answers to some of these great mysteries. Mr. Chairman, I'll be glad to answer any questions that come to mind of the committee. I know that you have a very busy agenda here, so I intentionally was pretty brief here.
Mr. Todd, I don't see any question, but I have one. You made mention of stimulus money. Would you go back over that again? You said you all were getting some stimulus money?
No, sir. There's 7 places in the economic stimulus bill appropriation that deal with health care information technology that we think we could produce some compelling proposals to the Department of Health and Human Services, the Office of the National Coordinator, the several places in the federal bureaucracy that would fund these directly, working with community hospitals. So we don't have any yet. We plan to compete aggressively and vigorously.
I don't see any questions. Thank you for that presentation and for the job that you do.
Thank you, sir.
Sherry Tucker.
Thank you. I'm Sherry Tucker. I'm the Executive Director of the Georgia Board for Physician Workforce and State Medical Education Board. I'll be starting on page 9 of the tracking sheet on the Georgia Board for Physician Workforce Administration. There's reductions totaling $197,000. Our admin budget is 1.5% of our overall budget, and this is a 23% reduction in some one-time funding and a deferment of a graduate medical education expansion study. In 1611, our graduate medical education program, this is money where we address the physician workforce needs of communities by supporting and developing medical education programs, residency programs with our teaching hospitals in Georgia. The overall recommendation is $431,397 reduction. This is a 4.4% overall reduction in the graduate medical education budget. In 1612, the Mercer School of Medicine operating grant. The operating grant is 47% of the Georgia Board's overall budget. This represents a 9.5% reduction in the operating grant for a total reduction of $2.3 million. The operating grant includes money for the Mercer Medical School in Macon as well as the Mercer Medical School Savannah campus. 1613, Morehouse School of Medicine. This also is a 9.5% reduction in the Morehouse operating grant budget, a total of $1.2 million. 1614 is the undergraduate medical education program of the board, which provides funding for Georgia residents who attend medical school at Emory, Morehouse, or Mercer. This reduction is a $407,000 reduction. And that is all the reductions for the Georgia Board for Physician Workforce.
Representative Hughley.
Thank you, Mr. Chairman. If you would please comment on what you project that these reductions will have on the quality of these programs, and what we can expect to happen with this 9.5%, particularly with the Morehouse program and the Mercer programs. What will be the effect?
They will, from the information that I've received from the medical schools, the reductions will cause faculty layoffs, staff layoffs, expansions that they already have in progress will have to be delayed.
Do you know how many staff we're talking about?
I don't have those exact numbers, no, ma'am.
Thank you.
I see no more questions. Thank you.
Okay, can I do the State Medical Education Board budget as well? Yeah,
I'm sorry.
that's okay. The State Medical Education Board provides scholarships and loan repayment for physicians to practice in rural Georgia. Their overall is an 8.3% reduction of $119,000, but these reductions are calling for a $25,000 reduction in our loan repayment program, and this year we had over 40 applicants, and the board was only able to award 17 awards at a reduced rate. This also calls for a $60,000 reduction in the scholarship program, and this would be 3 scholarship awards for that. And we currently have more applicants than we do awards for that program as well.
I see no questions.
Thank you.
LaShawn Hughes.
Good afternoon, Mr. Chairman. I'm presenting on behalf of the Composite State Board of Medical Examiners. Mr. Jeffrey will make the presentation.
Mr. Chairman, distinguished members, we're happy to be here again, this time talking about the FY10 budget. I'll start on page 8 of 11, 16.9, Composite Board of Medical Examiners. And I will skip the general things, the statewide things. That would be 9.1, 9.2, 9.3, and I'll pick up with 9.4. This, as you know, was the additional adjustment that came after the governor's revised revenue estimate for the past few months, indicating the next fiscal year. That amounts to another 1 percentage point of our original budget. I'm sorry. No, of the revised budget. And that is 20,000. Sorry, my eyes are playing tricks on me today. Been looking at numbers too long. $20,784, which we're going to have to take out of our regular operating expenses. As far as the personal services, we think we're looking good. We've already cut one position, a medical board agent. That, of course, is going to have some impact on our ability to investigate cases, and we've still got another position in our pocket that we may have to let go in case things get worse. But at this point, we think we're going to be fine largely because of the decreased employer contributions to the OPEB amounts. The rest of the things I think we've already gone over largely for amended fiscal year 2009, which we will simply carry over and continue to do in fiscal year 10. Those would include reducing the funds for case reviewers, those are the folks who take the complaints and the medical cases. They are licensed medical doctors, and they look at the medical records and determine whether or not these are potentially actionable complaints, as well as peer reviewers. As you'll recall from last time, we spoke about the peer review being an integral part of the due process part of licensure. These peer reviewers look at these cases after we examine the cases and determine that there's probably something there. The cases or I should say the charts are then handed over to peer reviewers, and the peer reviewers who are medical doctors licensed in medicine in Georgia and practicing that particular specialty will take a look at it and tell us whether or not, in their professional opinion, the care was substandard. Obviously, cutting the funds for that would obviously have a detrimental effect on our ability to prosecute those cases in a timely manner. Right now, we're able to take what we call the retained revenue, which we spoke about last time, and apply that for the next year or two. Hopefully, this crisis will have passed by then. Until then, we think we're still able to carry out our mission as the governor and as you members of the legislature have expected us to do and should continue to expect us to do. And other than that, I can answer any questions.
No, I see no questions. Thank you.
Thank you.
The department's next.
Mr. Chairman. Mr. Chairman, good afternoon. Good afternoon to all members of the committee. What we thought today is we would do is have me do a brief overview and to point out to you some very key points, and then have Carrie do a very detailed presentation, and then we do the Q&A together, if that pleases the committee. This afternoon I'm presenting to you the revised Governor's recommended budget for the Department of Community Health for fiscal year 2010. The best way to approach this is for me to be as straightforward and as blunt with you as possible about the budget, because I think it's critically important that you understand what it is that is proposed to occur. I wanted to start first with an overview of what the reductions will be as we go through the presentation line by line. Within the Medicaid program itself, the reductions will total $489.3 million for fiscal year 2010 as compared to the current 2009 base budget. That is a 21.9% reduction in state funds. For the Peach Care program, the reduction is $16.5 million, a reduction in state funds of 16.7%. Together they come and add up to $505 million. In the department's administration and healthcare access budget, the reduction in state funds is for $27.9 million, a reduction of 21.1%. And for the state health plan, the reduction in total funds is for $232 million. That includes both state funds and local board of education funds, etc. Within the state health plan itself, the key points to note are the following. The plan reductions included in the governor's revised budget account for the following. Number one, a reduction in the OPEB payments for a total of $118.5 million to not be paid. Number two, the reduction for state employees in terms of the state employer share being reduced from 75% of total annual premium cost to 70%, which amounts to an increase to the employees. And number three, a reduction again from the state health benefit plan fund balance for an additional $50 million. With respect to the state health benefit plan impacts, as per the governor's revised budget, the employer premium contributions will be decreased from 75% to 70% in fiscal year 2010. This change would apply to both active employees and retirees. The target for the employee share has in the past been 25% of the total premium costs. The actual percent paid by the employee is actually dependent upon the member's category as well as their choice of health plan and their tier of coverage. As per our actuary, Aon, the current employee share is on average in actuality of 23.4%. To increase that average up to 30% to match the recommended reduction of employer share to 70% would mean a total increase in the employee contribution for premium costs of 28.2% in fiscal year 2010. Regarding the retirees specifically, if the retirees chose not to participate in Medicare Advantage plan in fiscal year 2010, they would pay the same rates as active employees. The current Medicare retiree with full Medicare coverage in PPO plans pays at this point $32.20 a month. In calendar year 2010, under the proposed change, the SHPP PPO premium would average $42 a month, as compared to the SHBP Medicare Advantage plan, which would cost $22 a month. With respect to the Medicaid plan itself, and in particular, I wish to point out to you the following that we will also be going into greater detail in. The governor's original recommended budget that was presented back in December of 2008, including a new revenue source then that was a combination of a managed care fee and a new hospital fee. That, if passed, would have provided $317 million. His revised budget that has just been announced includes the following. Number one, federal stimulus funds for DCH or Medicaid. The total amount that the department received from Medicaid was $605 million. The corresponding amount of state funds that was removed and directed elsewhere to address the $1.6 billion state revenue deficit was $450 million, leaving the department with a net retained amount of $155 million. In addition, and included in the governor's revised recommended budget for Medicaid and for Peach Care are the reductions that result from the removal of the proposed managed care fee and hospital tax. This includes the deletion of all provider rate increases that were to have occurred in July of 2009. It also includes deletion of the trauma care system funds of $37 million and the deletion of funds for private hospitals participating in the DISH program. In addition to the discontinuation of the 2009 provider rate increases are provider cuts that are proposed. Provider rate cuts for the hospitals, total amount to be generated was $80.7 million, on average a 10% rate cut for hospitals. For the provider rate cuts across multiple provider groups, the total amount to be achieved was $68 million, which on average would equal a 6% rate cut. In total, for the Medicaid and Peach Care programs, the state fund reduction would be, again, $505.8 million. I'm going to ask Carrie to go through this budget with you in great detail, and then we'll do the Q&A together.
Go ahead.
Thank you. Thank you, Commissioner. Good afternoon, members of the committee. Mr. Chairman, as the Commissioner mentioned, I'll be going in detail through both the Governor's original recommendation for fiscal year 2010 as well as the revisions so that since we didn't have an opportunity for y'all to take a look at the original budget, thought that was important to go over. So we'll first start out with administration and healthcare access, then get into the original recommendations for Medicaid and Peach Care benefits, the state health benefit plan, and then what the department's budget would have looked like under that scenario, and then the governor's revised recommendations for those areas. Okay, my computer is not working. All right. It's wanting to be slow. All right. On this particular slide, this is our administrative budget, and do see the reference numbers to the tracking document, and I believe that begins with page 1 of the House version. The first items relate to our regular operating budget. The GATE 2010, there's a $179.9 thousand reduction at item 16.1.1. And that did not change in the governor's version, his revised version. Additionally, a $1.3 million reduction in our support costs for the department, as well as freezing our travel budget. That can be found at item 16.1.10. In the personal services line item, we have a cut of 7 vacant positions. In addition to freezing hiring, together those things have generated savings of over $1 million, as well as there's an elimination of pay raises and reductions in the state health benefit plan payments. In 2010, the original was $716,000, and the governor's revised was increased to a $728,000 reduction due to the additional reductions in state health benefit plan contributions. Contractual funds for both the revised and original version did not change at $11.1 million and $1 million for the health information exchange. And then finally, there's this is just one part of a transfer of funding between DHR and DCH for the Office of Regulatory Services. Here you see $378,000 transferring. In the healthcare access and improvement budget, you'll see a much larger amount. All total, that adds up to $15.1 million in both versions of the budget. On the next slide, we have changes to our healthcare access and improvement budgets. Again, in regular operating, we just have the GATE 2010 adjustment of just $361, and that's the same for both budgets. For personal services, there is 1 position cut as well as freezes in hiring, and you'll see also the same item with the elimination of pay raises and a reduction in state health benefit plan payments of $106,000 in 2010 original budget and $206,000 in the 2010 revised budget. The bulk of the reductions in this particular program are in contractual and grant services of $18.2 million, and the next slide will give you the breakdown of that. And then you see the $5.6 million being transferred from DHR to DCH for the Office of Regulatory Services. So in the Healthcare Access and Improvement Program, the original version, a $12.7 million reduction, and in the revised, a $12.8 million reduction. The next slide gives you the details of the grants and contracts that are being eliminated in the Healthcare Access and Improvement Program. I think most of these you saw in the 09 amended budget. There are a couple that are new. The Hugh Spalding Children's Hospital of $1.5 million. This was actually, we had a 3-year agreement to help the management and transition of Hugh Spalding's Children's Hospital by Children's Healthcare of Atlanta. That 3-year engagement or agreement ended in fiscal year 2009, and so these dollars were in our base budget, so we do not need them anymore, and they're therefore being cut at $1.5 million. Otherwise, these are the very same things that you saw in the 09 budget, and again, those are adding up to $18.2 million. So combining both of them, the bottom line really is about a 21% cut under either version of the budget that you look at. From the administration program, 14.2%, and in healthcare access, a very significant 50% cut. Moving into Medicaid benefits, just to kind of set the stage for what we, as the department was preparing our budget submission back in the fall, the various challenges that we were dealing with. I think the first one was in 2010 that there was a hole in the base budget of $204.9 million. You'll recall that our 09 budget was predicated on the use of 2008 prior year reserves. Those reserves will no longer be available in 2010, leaving that hole. We also had the required 5% reduction that the governor asked of us on the Medicaid and Peach Care program. That was $113.8 million. We also were facing the change in federal law that is to occur October 1 of 2009. This relates to our use of CMO provider fees. The regulation requires that as of October 1, if we as a state are to use managed care fees as a fund source, that we are to assess a provider fee on all managed care organizations, not just those with Medicaid. That's worth $104.5 million to the department currently. So if the department is not able to expand and remain compliant with the new federal changes, we would have to give up those dollars. And the fourth item on this list is the unknown impact of the economy on enrollment. I know we've had discussions before about the fact that enrollment is very much correlative to unemployment and the economy, and so of course we continue to monitor what that looks like, but I think as we were in the fall moving into a period that what we now know to be a recessionary period, we were concerned about how many more dollars the Medicaid program would need to cover those new applicants and new Medicaid members that would be coming to us for coverage. So when you add all that up, we were looking at about a $423 million minimum state fund need as we went into 2010. So as we attempted to address that staggering number, we really did look at different ways to cut our budget. I think really because of a lot of the things that we've done in the past, we really were out of, as what I would call, the low-hanging fruit, and we were looking at some very significant reductions to services and eligibility for our existing members, as well as putting on the table the fact that we would have to further defer the fiscal year 09 Medicaid provider rate increases that had been planned for July 1 of 08 and had been deferred at least a year, and our hope was that we could continue with those. But those things of being put on the table and evaluated, all totaled, added up to $128 million, which was almost $300 million less than the amount that we needed. So really the only other way to get to that level of reduction would be to do across-the-board provider rate cuts and eliminate optional services. And for example, one optional service is pharmacy. So obviously these would be very drastic reductions in effectively gutting the Medicaid program to completely bare bones. So all that being considered, when the governor released his original budget in January, he did take into account all of those situations and considerations, and he made various base adjustments and then suggested some new ways to finance the state's share of expenditures in the Medicaid program. The first thing, in order to meet our 5% budget reduction, again, we had to reduce at least $113.8 million. You'll see actually 4 different line items in your tracking sheet that add up to $170.6 million. For the most part, these are reductions related to the 09 provider rate increases that had originally been planned to use state funds to fund those, and later on you'll see in the governor's original budget that he instead recommended the use of managed care and hospital provider fees. So the state funds were reduced, and a very significant amount of state funds were supplanted with these anticipated new fees to the tune of $170.6 million. We also received funding on the flip side, a positive add to the base budget, and that is the replacement of those prior year reserves that had been lost, that $204 million that I mentioned earlier. That was provided for in state funds, combined with some At that point in time, we would say relatively nominal Medicaid growth and benefit payments. And you can see those two items at 16.2.10 and 16.5.15, again adding up to $222 million. The governor's recommendation for 2010 also took advantage of the use of tobacco and indigent care trust funds to the tune of $203.8 million. These were supplanting our existing state funds and replacing them with tobacco and indigent care trust fund money. The majority of that $203 million, in fact about 201 of it, was from tobacco funds that were being redirected to the department, and about $2.7 million from indigent care trust fund. The next two items are directly related to those new provider fee programs that I mentioned to you before. For $259.7 million, the governor is recommending the creation of a new hospital provider fee program, and I'll get into in just a bit how those funds would have been spent under his proposal. And then he also acknowledged that for us to maintain the $104.5 million that we had been counting on with our CMO provider fees, that we needed to remain compliant with federal regulations changing in October. He recognized an expansion of that program to assess the fee on all managed care plans, not just CMOs. And in doing so, that generated an additional $57.3 million with an assumption that for both of these fee programs, the fees were equivalent to 1.6% of annual expenditures beginning July 1st. Let me briefly talk a little bit about the managed care fee expansion in detail. The fee is today applied to our 3 managed care plans that serve our Medicaid and Peach Care program members. And as I mentioned, that with the federal law changing in October of this year, that would require us to expand that to both, not only including our Medicaid plans, but also the commercial plans. The existing state statute does link to the federal definition of managed care organization, so as the federal rules or federal definitions of the managed care provider class changes, so too would the state's definition automatically. There would be 15 insurance companies who would be impacted by this expansion, including the 3 that are already paying the CMO provider fee. The federal law allows us to assess up to 5.5% of annual premium revenue. And in fact, we're not the only state that uses this particular mechanism to finance Medicaid. There's actually 14 other states who have followed suit as well. There are options to do waivers for certain parts of the managed care plan's revenues to be exempted from the fee, and that would be for things like those particular plans providing insurance to new low-income families as a way to address the uninsured and Medicaid enrollment issue. So all totaled, the revenues that all of these health insurance companies cumulatively received in calendar year 2007 was a little over $10 billion. Assuming that some of that revenue would not be necessarily eligible for the assessment, we really were looking at about a $7 billion pot of money that would be assessed, with a 1.6% annual fee would generate $107 million, and you can see if you went all the way up to the maximum allowed of 5.5%, you could generate $305 million. And this particular slide gives you a little more of the detail of the 15 companies that would be subject to the fee, and you can see what their projected fiscal 2010 managed care premium revenues would be. Again, that $7 billion figure cumulatively, what the fee at 1.6% would look like for each plan, and then as a percent of total revenue for all insurers, that actually equates to less than 1%. On the hospitals tax, the governor's proposal would require new legislation, and again, as is the case with the managed care provider fee, exemptions are possible. That does require federal approval to get those exemptions. Just to give you the landscape, there's about 153 hospitals in Georgia. Again, some of those could be exempted from paying the fee or paying some portion of the fee. Pretty much, as you see on the list, they would have to be either financially distressed, a rural hospital, a sole community hospital as far as within a community, or a psychiatric hospital. And very much like the managed care provider fee, the hospital provider tax is in use in 20 states. Looking at total hospital net patient revenues, that equates to $16.3 billion. Again, the governor's proposal is 1.6% of that amount effective July 1, which would generate $259 million. Now, the combination of the new fees from both the hospitals and the expanded managed care programs again adds up to $317 million, and this particular slide gives you the list of how those funds would be spent. At the top of the list is giving back to the department to fund projected Medicaid needs. You'll see those on 16.5.5 and 16.7.2. Those add up to almost $175 million. And then the rest of the fees were used to implement, expand fiscal year 2009 rate increases that for providers in Medicaid that had been deferred in 09 until 010, so it would fund those. Item number 2 is for inpatient and outpatient hospitals to the tune of $52 million. It would also fund dish payments for private hospitals, and that is in the Indigent Care Trust Fund budget. There's also $37 million in there designated for the Georgia Trauma Network Commission, which, by the way, these dollars were linked to funding in the DHR budget of $23 million. That was also earmarked for the Trauma Network. But those $23 million, there was a different fund source. It was not the fees. Items number 5, 6, and 7, again, more provider rate increases. For number 5, for our waiver programs, these are for providers of long-term care community-based services. Item 6, for physicians, ambulance providers, home health, health check, digital mammography, global maternity, and independent care waiver program personal support. And then finally, item number 7 was $15 million to update several things in the nursing home program. Again, all of those adding up to $317 million, and again, the source being from the hospital and managed care provider fees. There are other items in our budget in addition to the use of fees and the supplantation of state with tobacco and fee funding. There's actually some state fund cuts to the tune of $20.5 million. 3 of those items are actually continuations of new initiatives that were started in fiscal year 2009. Hopefully you'll recall the information about the Paris Initiative, which is using interstate data matching to verify eligibility is accurate. The second item is conducting expedited reviews for certain members that we refer to as ex parte. And then the third item being related to improving our opportunities to identify and prevent fraud and abuse. There is one new initiative to reduce state fund costs, and that is changing a reimbursement methodology for injectable drugs provided in a physician's office and for the way we pay for durable medical equipment. We're actually trying to align the reimbursement methodology for these particular services similar to the methodologies that had been proposed in the rate increase for physician services. And so, again, all of those items add up to a $20.5 million reduction in state funds. We do have one enhancement item, and that is to provide for 100 new slots for the independent care waiver program, and that was to the tune of $1.5 million, and you can see that at item 16.2.15. And, in fact, that particular enhancement also is included in the governor's revised recommended 010 budget. So, in trying to give you a picture of the various fund sources that are used to pull the federal dollars down for Medicaid, you can see in this chart in the 2009 in our base, we have about $2 billion in the budget for state funds, $51 million for tobacco, $121 million for nursing home fees, and $153 million for CMO fees. Going into the 2010 year, the original recommendation, again, general state funds are reduced down to $1.8 billion or $170 million reduction. However, they are replaced by increases in the tobacco funds of $200 million, a very marginal increase in nursing home fees, reductions in the CMO fees, but the recognition of, again, those new fees for the expansion of the HMO program, HMO provider fee program, and the hospital fees. So you can see how that all adds up. All of these dollars are eligible to match federal dollars for the payment of Medicaid and Peach Care benefits. Skipping quickly over to the health benefit plan. Again, this is still the governor's original proposal. We're happy to report that at the end of June of 2008, or in fiscal year 2008, we had a fund balance in the health benefit plan of about $473 million. What that fund balance is reflected of is when you compare the plan's assets to its liabilities, the $473 million is what remains when you do that subtraction. At the time, prior to any changes in the 2009 budget, we had expected the employer contribution rates to increase and the fund balance to grow to $672 million by the end of June of this year, of fiscal year 2009. In the governor's amended budget, and of course you, I think, have already, of course, seen that, and it's the amended budget is making its way through conference and will soon be done. But that budget does reflect changes to what employers are contributing, particularly those agencies who contribute 8% of payroll, as well as the Department of Education, who contributes quarterly payments to the plan. And you can see when we started in July of 2008, state agencies were paying 22.16% of payroll. February, that dropped to 1.9%, and then in March through the rest of the fiscal year, that will actually be at 0. We will receive no contribution from them. For teachers, we're going from 18.5% down to 3.6%. And for the DOE budget, the last 6 months of the year, we will basically receive no quarterly contributions from them. So what does that really effectively mean? What that means is the current year revenues are obviously reduced because these contribution rates have been reduced, meaning that revenues are projected to be lower than expenses in fiscal 2009, and that deficit situation is basically covered by the fact that we have a fund balance. So that fund balance will supplement, if you will, our annual revenues. When we get done in the end of fiscal 2009, we expect that fund balance to be down around $155 million as a result of all of these reductions. That's important because of what it looks like in 2010. 2010, the employee premiums had, for calendar year 2010, which would be a January 1st, 2010 effective date, the original recommendation was to have employees' premiums increase only if they were in plans that were not considered consumer-directed health plans. For example, if they were in the HMO or PPO, they would have seen a 5% increase. That would have generated about $17 million in revenue for the plan. And again, keep in mind this is the original recommendation. As the Commissioner already mentioned, the revised recommendation is much different. Also for 2010, there is an intent to suspend OPEB contributions, OPEB meaning the other post-employment benefits, meaning when people retire at some point in the future, as they retain coverage in the plan as a retiree, there's a liability for that. And General Accounting Standard Board requirements say we need to start preparing for that by doing some pre-funding. The state was able to start that in fiscal year 2008. We had about 4% of payroll that was contributed by state agencies going into the OPEB trust fund. That would be suspended in fiscal year 2010. And so you can see that in 2010, that state agency payroll percentage does come down by that 4% amount. And that's estimated to be a reduction in contributions to the plan of $118 million, and as a result, it's also we would not be making contributions to the OPEB trust fund. So, given the governor's recommendations for 2009 and 10, at the end of the day, our fund balance by the end of June of 2010 would be down to around $34 million. That's going to be a number you'll want to remember because it plays a key in the governor's revised recommendation that I'll be mentioning in just a little bit. So kind of bottom line for the governor's original recommendation, the department did see an increase in our state funds with all said and done of $212 million, or this was actually an 8.5% increase over our base. The majority of it was in the Medicaid program, and again, it was basically a result of the recognition of those new fees. Those fees look like a state fund in the budget, and again are able to be matched with federal dollars. Moving into the revised budget recommendations, again, this is what the governor just announced. I believe it was last week on the 3rd when he announced reductions in his revenue estimates as well as recognition of the stimulus package or the stimulus bill that's providing additional federal dollars for Medicaid. His budget does consider all that, and that's what I plan to go over now. Pretty much the bottom line changes from his original recommendation is, first of all, he's considered more recent enrollment and inflation projections for Medicaid. His original budget was predicated on what we thought enrollment was going to do in Medicaid back in the summer, back in July, August timeframe. And obviously there's quite a bit that has changed since then. Primarily what has changed is we're seeing more people applying for Medicaid, and we're also expecting, with unemployment being higher than initially anticipated, that those folks who have lost their jobs will at some point apply for Medicaid and be covered for some period of time. The second big item is that his revised budget is no longer predicated on the use of either CMO, HMO, or hospital fees. So where that was a very large number in the budget of $317 million, that is now backed out. So as a result, all of the uses of those fees have now been eliminated. So no provider rate increases, and funding for the private dish hospitals and trauma funding has been zeroed. He's also recommending provider reimbursement cuts. The commissioner mentioned 10% reductions for hospitals and 6% for most other providers. And then, of course, there is the reflection of stimulus funding for the enhanced FMAP. So what the budget reflects is the fact that we will have more federal funds coming in, meaning that we need less state funds to maintain the total expenditure level. Let me give you a little more detail about our updated projections. Again, I mentioned some of our original assumptions were from way back in July. Obviously, we have more information since then. Back then, we thought our Medicaid enrollment was actually going to be pretty moderate between June of 2009 and June of 10, about 1.5% increase in Medicaid and about a 10% increase in Peach Care, with inflation being about 3.6%. I think you've seen this chart before when we've talked to you a little bit about fiscal year 2009 and what was going on. The red line is actual unemployment for the state, seasonally adjusted, and the green triangles were what had originally been projected back in July for unemployment. You can see that the actual since then, which is by the light blue smaller triangles, has obviously far exceeded that original projection, and even the more recent quarterly projection that we've done, it threatens to exceed that as well. So obviously something we continue to monitor on at a monthly basis to see how that might need to reflect in our projections. When we consider that in our low-income Medicaid enrollment projection, you can see by this slide the bars that are transparent, that was our original projection, and you can see we've reprojected to show that trend in numbers of people in the low-income Medicaid program growing quite a bit. And then in Peach Care, we actually had to revise and to show that we really thought enrollment was going to peak a lot earlier than it has. In fact, when we thought it was going to go up, what we found was that for some period of time it had gone down. And what we think is happening is that there are more people, more children in particular, obviously, who are eligible for Medicaid because they have lower incomes than what they would qualify for in Peach Care. So in effect, they've dropped out of the Peach Care program pool down into the low-income Medicaid pool. On the inflation side, we do look to a national expert on what medical inflation will look like going forward. For 2010, we had originally projected 3.6% based on The global insight information that was available in the summer, that's now come down to 3.3%, so a little bit of savings on the per member per month side of the cost equation. And so our revised considerations for Medicaid enrollment growth are up to 7% increase in enrollment, 22% in Peach Care, expecting Peach Care to kind of catch up to where we thought it might be 6 months ago, and then a lower inflation adjustment. If you want to compare the original to the revised, you can see that we've added an assumption of 20,000 more Medicaid members, almost 6,000 more Peach Care members, and we're assuming that unemployment would, at this point, possibly max out as high as 10% the last quarter of this calendar year. The other revision in the governor's budget, again, as I mentioned, is the fact that the budget no longer is predicated on the use of hospital and managed care fees. This is basically the same slide you just saw under the original proposal, except everything's in negatives because that's now being taken out of the proposed adds in the budget. So again, those $317 million in fees gone away. There are 2 reimbursement reductions, as we mentioned before, inpatient and outpatient hospital rates reduced by 10%, or an $80.7 million cut, and other Medicaid provider payments down by 6%. There are some exceptions, and you see those here. They're primarily long-term care programs. So these add up to about $150 million in cuts. As far as the federal stimulus package is concerned, we do project that we will receive quite an increase in the FMAP, or the Federal Medical Assistance percentage, for state fiscals 09 and 10. Currently, we're around 65%. We expect in 09 that that'll go up to 71 and all the way up to almost 75 in 2010. In 2010, that 10-point change, if you will, is expected to generate about $605 million in additional federal funds. The budget that you see in line items 16.2.1 and 16.5.1, you actually see a smaller amount. You see only $450 million. And what's going on there is the governor's budget allows the department to retain $155 million for Medicaid benefits growth. So instead of them showing the full cut for the $605 million and then the add back of $155 for benefits, they've netted it out all on that one line item. But again, you can see that netted number on 16.2.1 and 16.5.1. So all totaled, let me give you the summary here. We have the reduction in state funds from FMAP, and so federal funds will come in and replace those state funds. The department will retain some of those state funds for enrollment growth of $155 million. The fees that had originally been contemplated for hospital and HMO, again, those that added up to $317 million, that now has to be backed out of the budget. For all but $175 million, that's backed out by us just not doing the enhancements for which the fees were originally intended. And by that I mean the provider rate increases and the funding for DISH and private DISH hospitals and for trauma funding. The fees initially had supplanted state funds to the tune of $175 million. So when the fees are backed out, we need to replace that. So you'll see an add of $175 million back in state funds. You'll see the provider rate decreases in state funds of $149.6 million, and then there's an additional $13.3 million in tobacco funds that have been added, and those are supplanting a state fund cut of the same amount. So all totaled, state funds are reduced by $438.6 million. Hospital fees are eliminated, as an equivalent of $317. CMO fees have been adjusted to reflect the fact that we do still have a CMO provider fee program through September 30th at 5.5%, as compared to the governor's projection or the governor's original recommendation of having the CMOs at 1.6% beginning in July. So there's an adjustment that is made for that change. So bottom line, of all the state funds that are available or were available to the department in the change of $749 million. So again, this is the difference in the governor's first budget and the one that he just released last week. So when you look at, again, the funds available to the department in terms of comparing our 09 base to the new recommendation, so we're doing a different comparison here, not comparing the governor's original 010 to new 010. We're comparing the governor's new 010 to our 09 base. We've actually had a decrease of $504 million, or 21.7%. State funds have been cut by a little more than $700 million. We've picked up quite a few tobacco funds of $215 million more, nursing home fees of a moderate increase of about $2 million, and CMO fees have been dropped because, again, the assumption is that we're going to go from 5.5% down to just 1 quarter's worth, since that program will be ending in September. So let me quickly go over the change in the state health benefit plan in the governor's revised recommendations and wrap up, and then we'll be ready for questions. As the commissioner mentioned, in the health benefit plan for fiscal year 2010, there is an assumption about the increase in what employee premiums would be. This would be effective for January 1st, 2010. It's for a calendar year 2010 premium change. As she mentioned, that typically we have tried to target that members pay about 25% of the premium cost, and the governor's proposal would have that go to 30%. Given where we actually are today, that results in about a 28% increase in premiums, which generates almost $80 million in new revenue. We are also would be using the rest of the fund balance. If you remember, I said keep in mind that $34 million, 630.010 fund balance in the health benefit plan. That would also be used. So by virtue of these dollars being available, the employer side of the contributions can be reduced by $114 million, and that would be achieved by reducing the percent of payroll for state agencies from 17.8% down to 16.5%, and for teachers from 18.5% down to 17.2%. So by making those percent of payroll adjustment, that saves the employer side $113.7, and that revenue is made up by the increase in employee premiums and the fund balance. To give you an example of what premium changes might look like, again, I mentioned a 28.2% increase. Just as, again, examples, I'm using the calendar year 09 premiums that members pay today on a monthly basis, and then showing you what that would look like with a 28.2% increase. And again, this is just a small sample of the various options that our members have. But if you're in the PPO and you have single coverage, you would go from $86.10 up to $110.38, or a $24 a month increase. If you have family coverage, that increase would be about $74 a month. If you are in the consumer-directed health plan options, as you guys I think are aware, we're trying to make those premium prices very attractive to get people to move into them, because we believe they are cost-effective plans, plan designs for our members. Those premiums would go from $56.92 for single coverage up to $72.97, so a $16 increase, a little bit cheaper because it's a less expensive product, and family coverage would go up by $50. If you are a post-65 retired member who is on Medicare and you are in the Medicare Advantage plan this year, you're currently paying $17.50. Next year you would pay $22.44, or almost a $5 increase. So because of the reduction in employer contributions and our directive to use the remainder of the fund balance would be at zero by the end of June of 2010. The plan is still fully funded from an accrued basis. That is, our assets will cover liabilities, but there is no fund balance. So any adverse fluctuation would be problematic for us. So in summary, the governor's revised recommendation for state funds, a very marked difference from his original proposal. On the Medicaid side, $489 million worth of reductions in state funds. Again, a lot of that is the supplantation of federal Medicaid dollars from the stimulus bill, but that's a 23% reduction. On the Peach Care side, a 16% reduction, and that's mostly because of the rate reductions for providers. Bottom line for the department, we have a $537 million decrease as compared to our current 09 budget, and that's a 21% reduction. And that is the conclusion of my detailed presentation.
I'd like to start off with what appears to be an elusive number. The amount of money generated by the increase to FMAP. There's numbers all over everywhere, and I, for one, am having a very difficult time trying to figure out what's what. NCSL initially projected that the state of Georgia would get $775 million in our 2010. Government Accountability Office suggested that it would be $790 million. And as I read the letter that the governor sent to the members of the General Assembly, it looks like to me he's recognizing $526 million of that money. Where's the difference?
I think on the tracking document, what's recognized is actually $450 million as far as the line item specifically for the stimulus bill. If you will go back to slide 36 of the presentation, if you have that copy in front of you, I think, first of all, as we understand and looking at the numbers and even running them independently ourselves, of taking our budget projections with the original FMAP and then plugging in the new FMAP at the higher enhanced rate, which I don't think there's any discrepancies between any of the budget offices of what the new FMAP itself is as far as what percentage of a dollar that's funded by federal funds. We agree with the fact that it's worth $605 million. Why is that different than what federal sources have issued? First, I think the original, some of the original numbers that had been published were very high. I think they originally had come from the Congressional Budget Office, and upon some further research, I think we figured out that there were some DISH funds in their calculations that are not subject to FMAP. So that brings the number down. The second thing that brings the number down is that we have carved out a very significant amount of expenditures in the Medicaid budget that will no longer be subject to FMAP. For example, most of the use of the hospital and CMO fees to the tune of $317 million, with the exception of trauma funds and the DISH funds, because those are over in the Indigent Care Trust Fund. Those dollars, if we're not doing provider rate increases, there's no federal funds, obviously, to earn an enhancement on. So in other words, we're cutting the Medicaid base, and so therefore you get less federal dollars. Likewise, when you go in and reduce hospital expenditures by 10% and most other provider expenditures by 6%, you're again cutting the base. And so when you cut the base, there are less federal funds to be earned because you're spending less money. So that's how you get from your $700 million range that you talked about down to a $605 range. And then from there, we have, I think we've mentioned to you before, that given enrollment increases that are projected through fiscal year 2010, the department has a state fund need. We were in a deficit situation, on a cash deficit situation. And so, again, I think the way the budget document looks is that you don't see the 605 as the full amount being earned as a cut, and then an add back of $155 million that we're being able to retain in order to fill that that need for an updated enrollment projection.
Again, I'm trying to tie what you're telling me into what the governor sent to the General Assembly. What the governor's letter says is recognizing FMAP Medicaid funding of $526 million. Now, as far as the department retaining $155 million, I can't find that in this letter. I mean, where'd that come from?
Well,
I'm trying to figure out what the governor's recommendation is per this letter,
right,
versus what you're telling us. I mean, if the governor meant to increase benefits by $155 million, he forgot to put it on this piece of paper.
well, I think he did that by virtue of just not cutting all of the dollars out of the budget that are related to the FMAP ad. There's also
He did what?
Well, I mean, there's 600 for the department, DCH. Now, DHR also has an impact for enhanced FMAP because they have state funds in their budget that will draw down more federal funds for Medicaid. So his letter is for both departments together. I think part of the problem is we're only giving you our side, our piece of it. There is a DHR piece that also would need to be accounted for that helps piece together this puzzle here. But instead of, let's assume that we didn't have an enrollment figure, we didn't have a need for more money because of enrollment. The governor would have taken $605 million from our budget and then whatever he took from DHR's budget and said, you don't need those state funds anymore because the federal funds are going to come in and replace it, so you'll be net zero. I mean, that's what we're doing, is supplanting state funds with federal funds.
Well, where is he showing it in this letter?
Well, it's shown because it's a net.
Where?
It's that line item. That's
your
500 and I think it's 25 million.
So what he should have, I mean, I guess to properly describe it, he would have put the $155 million in and said this is a net amount or something like that.
It would have perhaps been more clear, transparent for him to have shown the full amount and then shown the add back of the $155 million for the benefits. That did not occur in the letter. It's a net. You're seeing the net number in the letter.
So the other thing that you said is that it's reduced. In other words, the $80 million that hospitals are being proposed to be cut in here, and the $68 million for everybody else. That also further reduces the amount of FMAP money we get. Is that?
Yes, sir. Yes.
By how much? Do y'all have calculations on that?
I think it's approximately. Let me get you that number. I have it calculated. I don't have it memorized.
Well, this committee is obviously charged with making our budget recommendations to the full committee, and I'm still completely confused as to the legitimacy and the source of figuring out how much stimulus money are we dealing with here. Where can we get that? Well, you know, we talked to OPV and they declined to come today, but how are we going to write a budget if we don't have accurate information on how much stimulus money we're going to be getting?
Mr. Chairman, I believe I'm giving you accurate information. I'm happy to sit down with Margie and show her our projection models with the FMAP in the original form and the enhanced FMAP, and she can see the difference to get to the $605 million. That number is easily demonstrated. I don't know what more to...
Well, if you would, that would certainly be appreciated. It appears to me that it's $536 million, $526 million in here, and I think we definitely going to have to have further conversations with the department to try to get to the bottom of this. Representative Shaw.
Thank you, Mr. Chairman. Commissioner, you, of course, have community health, which is dear to all of us because it's not an easy committee to serve on. But how do you feel about the governor taking money that we have sent down from the feds and using it for trooper cars, prisons, and fishing lakes when it ought to go to the Medicaid and the hospitals?
Representative, I'm going to first do a disclosure. I misconfessed. But I believe that there are few things that are as important as health and health care. Well, that's just a personal bias. But I will also tell you that I'm not the governor of the state of Georgia, and I'm not responsible for all of the state budget. I don't know where the $450 million has gone to. It may have gone to things that are critically important. I don't know. I will tell you that if it was possible that the money could stay with us, we know that we could put it to very good use. We are concerned about the health care of the people of Georgia and the people who are in our programs.
And I know you are, and that's all I'm asking you as a member of this committee. I think we need to have folks like you that runs the department say how critical. I think our folks on the second floors forgot that we're going to lose rural hospitals and we're going to lose health care if we don't use every dime that comes from the federal government. So that's what I'm begging and pleading to you to, talk to the government, because I mean we got a tough deal, but we know we're not getting all the money that was sent down for health care. Something's wrong. Thank you, Mr. Chairman.
Representative Hughley.
Thank you, Mr. Chairman. My colleague over there mentioned what I am concerned about also, and I have difficulty trying to explain to hospitals and providers that we're getting money from the federal government and we're asking them to take additional decreases in terms of their rates, and I'm really concerned about the citizens of our state and what kind of outcomes do we expect to get out of this budget, knowing everything that we know.
Representative, if the cuts occur across the board as they are planned, we know that we will lose some members of the provider networks. We know that we will lose some providers in health care. We also know that unless additional revenue is put in to the health care budget for both Medicaid and for SCHIP, that we will have issues going forward. We know this. But until we can receive a commitment to actually using other sources of revenue, and I think that's part of what's being put on the table, if I may be so blunt.
Mm-hmm.
And the bluntness is it going to be the stimulus dollars, or is it going to be a combination of some of the fees? Is it going to be a tobacco tax? What is it going to take to actually get the budget for health care stabilized? The cuts that are put on the table will impact the provider network and access to health care across the state of Georgia. Healthcare is not immune to the economic changes. We already know that there are hospitals and provider groups that are already closing their doors, reducing their staffing hours, reducing access.
Mm-hmm.
This is going to be in addition to that.
Thank you, Mr. Chairman.
Representative Gardner.
Thank you, Mr. Chairman. I guess I'm also confused. I mean, if there is some $700 million that is designated for Medicaid, we are leaving, I mean, by making the cuts we've made, we are leaving money on the table, federal money that might be available to us. Is that correct?
That is correct. However, I'd like to point out one other thing. You have the ability to see the remainder of the state budget. Are the places where the state dollars are being directed to, is there a critical need there as well? That's the only thing that can cause me to have some pause.
Even if they're worthy needs, if it's designated for Medicare, how can it be used for another purpose?
How can it, or will it?
What? Pardon me? I mean, I don't understand. If it's, I'm assuming that the Medicaid billing goes according to a certain billing procedure, and that you're only going to get that money if you can bill for those services. I mean, is it just a block grant, or do you have to bill for the Medicaid services?
It's not a block grant, madam.
So we
It's-
will just be leaving federal dollars
Yes,
in Washington so they can send it to Texas or to somewhere else.
or wherever, but the state dollars, that's the critical piece. Where are the state dollars being used?
Let me follow up on the proposed cuts. The $80 million for hospitals, what does that equate to in total dollars? I mean, in other words, that's $80 million is state dollars. What's
80 million times is set, which matched by 74% in federal dollars.
you know? So we keep talking about an $80 million cut, but it's
It's more.
It's
It's
lots more than that. How much is it? So $320 million cut to hospitals. So that's what this budget calls for. Is that correct? Let me ask you this. I noticed that the $68 million, in other words, hospitals in this budget proposal from the government proposes hospitals be cut 10%, and some other providers be cut 6%, and some cut none. Do you all know the basis of why you would cut one 10%, one 6%, and some none?
I don't know.
Representative Gardner.
Well, I'm still trying to straighten out in my mind what's happening here. I noticed in the original recommendation there was a recommendation for a hospital provider fee that seemed to bring in something like $260 million, plus the CMO assessment fee, which was then rejected. But the numbers seem remarkably similar. I mean, it's just a different way to do the same thing? I mean, at least the provider fee would help us bring in additional federal dollars as opposed to leaving them on the table, wouldn't they?
It would.
So that was why you originally had recommended that, so that we would
Yes.
be able to serve more Medicaid and Peach Care recipients.
And be better prepared to address the onslaught of enrollment that we anticipate coming.
Mm-hmm. Thank you.
Any more questions from Representative Shaw?
Thank you, Mr. Chairman. When we're talking about increasing the employee share, you just it showed employee and spouse. Now we have three tiers. We got employee and employee and family. Now we have employee, spouse, and employee or four, whatever. Is that going to be deleted and it's going to go straight employee family? Because it didn't show the other tier in your breakdown.
We were just trying to give you examples so that you'd get a feel for the impact.
And my other question, Mr. Chairman, if you will, is the Regents plan going to go to 70-30 also?
They are already there.
They're there now. Thank you.
I don't see any further questions. Thank you very much. Oh, wait just a second. I'm sorry. Commissioner, were you going to address these CPT code revisions at this meeting, or
If you'd like.
if you don't mind, touch?
I think we have passed out to you a one-pager that actually outlines how the department goes about setting its rates for providers. We use a nationally created standard that is shared with us through the Centers for Medicare and Medicaid Services. That also includes input from the American Medical Association. We chose a national standard to try to be as objective as possible and to try to make sure that we did not show any favoritism to one medical or surgical specialty over another, and so that we could have some consistency. The standard is updated on an annual basis with the evaluation on value points set for each code set for each service. Each year the code sets are updated so that new services are assigned new codes, but some of the continuing services may have their codes and values reset according to this committee's evaluation. For this year, some of the code sets that are impacted are for neonatal services, but there is also a host of other physician services specialties that are actually also impacted. When I say impacted, some of the code set values are decreased, some of the code set values are increased. The physician specialties that have the increase are quite happy because they're getting paid a little bit more than they had been in previous years. The ones that are decreased are unhappy. However, what we've tried to do is to maintain the use of that national standard and not to deviate based on any individual subspecialty, so that we would not appear to be showing favoritism toward one over another. The ups and downs are actually kind of equilibrate so that we are actually remaining budget neutral overall. A question has arisen as to whether or not our code sets were applied fairly and accurately. And I believe one of the questions that was raised was whether or not something about the numbering of the code sets, if we had skipped some or if we were using some inappropriately. We did actually call back to CMS and also did actually assess what they considered a concern then was the exclusion of some code sets by the American Medical Association when they did the evaluation. However, that error was not carried down by the state as we did not use those exclusions.
Thank you for addressing that. I don't see any further questions. That concludes our meeting. We stand adjourned.